Hey everybody, my name is Leonard Timoney. I've set up this website with the intention to provide a useful teaching resource for dermatology. It's aimed at students, people doing the BST, GP trainees and GPs, and maybe people who are just starting out in a dermatology rotation. So this website, it's still in its very early days, so I'd appreciate any advice at all. So please feel free to contact me with any suggestions or advice. The contact form is at the bottom of the homepage here, so you can just leave your details and email and I can get back to you. Just a small bit about myself first. At this moment I'm doing my BST in general medicine. I do though have an interest in dermatology. I've worked as a dermatology reg for 2 years, 1 year in Ireland and 1 year in Glasgow. I have a diploma from Australia and I've done a few other bits and pieces here and there as well. So for this part of the website, I'm going to talk about the MRCP section. So this is aimed at people who are preparing for their MRCPs. And the first two parts are obviously MCQs, and they cover a huge range of topics which could potentially come up. Therefore, I've covered a wide range of topics, but very concisely. But hopefully it's enough information there to get you a few marks on the exam. If you do want any more information on any particular topics, you could consider looking at the GP education section. And I'm going to try to add more topics on this in the coming weeks and months. As there are a lot of topics, I have just listed them in order. So this might make it easier for you to find them if you want to look at any specific topic. So enough with the preamble, let's just get started on the various topics. And the first topic is psoriasis. Psoriasis is, of course, one of the commonest disorders we see in dermatology. It can affect 1 to 3% of the population, and it has kind of bimodal peak of onset. So it can one peak is at 15 to 25 years, and the other is 50 to 60 years. It can be associated with a psoriatic arthritis in up to 40% of the population, and this is an inflammatory type of arthritis. Now, this can manifest in multiple ways. It can manifest as a polyarthritis, an oligoarthritis, it can arthritis mutilans, which is a very severe deforming arthritis of the hands. The arthritis can be localized just to the DIP joints and can also cause a dactylitis, which is swelling of the digits into sausage shape. It can also present as a sacralitis with similar symptoms and signs to Angst-Bond. You can also get nail changes commonly. So pitting can often be seen, and this is small little indents or depressions seen on the nail surface. You can also get onycholysis, which is separation of the nail plate from the nail bed, as we can see here. And if it gets severe, you can even get dystrophy, in which you get deformation of the nails with extra keratin in them and increased brittleness. So psoriasis is characterized by abnormally excessive and rapid growth of the epidermal layer of the skin, with the proliferation of keratinocytes, which are the main cells in the epidermis, and they go through a much quicker life cycle. It's quite complex, but it's in part due to immune dysregulation, which basically means there's a different profile of immune cells and cytokines in the skin, causing this abnormal skin appearance.
We will now go on to the various subtypes of psoriasis, and the commonest type of psoriasis that we see is chronic plaque psoriasis. And this tends to be characterized by these kind of salmon pink hyperkeratotic plaques, which often occur on the extensor surfaces. The scale that we see is often a silvery type of scale. So once you've seen enough of these plaques, you can kind of pick out that it's psoriasis straight away. As I mentioned, often it's the extensor surfaces of the elbows and knees that are affected. However, other common areas that we can see affected are the lower back, the ears, and the scalp. Here we can see psoriasis involving the scalp, and we've got this kind of pinky red base with a large build-up of scale. And this can cause the patient quite a bit of distress and also a lot of embarrassment. And psoriasis in the scalp can also be very itchy at times also. Another common subtype is guttate psoriasis, and in Latin guttate means raindrop. This type of psoriasis often follows an upper respiratory tract infection such as a streptococcal sore throat, and it often occurs about 2 weeks after the infection, and it can come on quite suddenly. You often see these multiple small papules and small plaques which can be scattered throughout the trunk and limbs. However, the palms and soles are usually spared, and the diagnosis is usually a clinical one. The good news is that it usually resolves spontaneously over a few weeks. However, and often we just give simple moisturizers for this. However, if it is itchy, you can consider a topical steroid. And if it really is bothering the patient, you can even consider giving them narrow band UVB light. And essentially, this means putting them in something like a photo booth about 3 times a week for a period of around 10 weeks. And they just have to go in for a few minutes at a time. And you shine a specific wavelength of UVB light on them. And this can be very effective, but it is time consuming. Another variant of psoriasis is pustular psoriasis, and this can tend to be generalized or localized. The generalized form often occurs in a patient in whom oral steroids have been quickly withdrawn, and it can really be quite severe, as you can see in the image here. We see here an erythematous base with many pustules scattered throughout, and this patient can be very unwell. The differential diagnosis here would be a pustular drug eruption. The localized variant of pustular psoriasis often affects the palms and soles of the feet, and the pustules can be varied in appearance due to the thickness of skin in these areas, and the pustules can appear brown, they can appear red, or they can appear yellow-green. Erythrodermic psoriasis can also occur sometimes, and erythroderma means widespread erythema of the skin with about greater than 90% of the body surface area affected, and this is just one of the causes of erythroderma. So other causes include eczema, drug eruptions, and many other causes. This type of erythrodermic psoriasis may or may not be preceded by the usual type of psoriasis, so they may have no history of psoriasis at all, and the patients that we see can either be stable and have had it for months or years, or sometimes they can be very systemically unwell. In this image here, we can see the silvery scale that we see with psoriasis. So if you saw this patient, that type of scale would lead you to a suspicion that the cause of erythroderma is psoriasis. And general flare-ups of psoriasis can be due to many things. So as mentioned previously, it can be due to a streptococcal sore throat, it can be due to trauma, as mentioned, the Koebner phenomenon, and many medications as well can cause it. So things like beta blockers, antimalarials, and lithium. Now, there are multiple options for the treatment of psoriasis. Kind of mild to moderate disease, so if the body surface area affected isn't too high, or if it doesn't bother the patient too much, we can consider topical treatments. So I won't go into them in great detail, but you can use topical steroids, topical coal tar, you can use topical calcipotriol, which is basically a vitamin D derivative, and the commonly used one is a thing called Dovanex. And as mentioned previously, we can sometimes also use phototherapy. So narrowband UVB tends to be the commonest one used. For sometimes if it's hand or foot psoriasis, we might be able to use a thing called Puva, which I won't go into here. Now, if the psoriasis is more severe, you may need to consider systemic treatment. The kind of old classic mainstays, which are still used very commonly, are methotrexate and cyclosporin. There's a whole host of other types of oral treatments that can be used also. And then there's these new biological immune modifying agents. One such example of these would be the anti-TNF agents such as adalimumab. However, there's a whole different range of agents that are coming out on the market nowadays. Moving on to eczema now. Again, eczema is one of the commonest dermatological conditions we see, and in particular I'll talk about atopic eczema here. In general, the terms eczema and dermatitis can be used interchangeably. Now, there's an incidence of about up to 5% in children, and about 85% of these will have the disease before the age of 5. As we all know, there's a co-association with asthma and hay fever, and to a much lesser extent food allergy. As opposed to psoriasis, which occurs on the extensor surfaces, eczema tends to affect the flexural surfaces. And regarding the pathogenesis of eczema, it's basically a barrier defect. So water can escape from the skin very easily, leaving it dry, and also irritants and allergens can get into the skin, which can cause inflammation. The combination of dry skin and inflammation leads to itch and this leads to scratching, and this makes the inflammation worse, and all this leads to a vicious cycle, a vicious itch-scratch cycle. Now, the chronic itching and inflammation then can also sometimes lead to hypo or hyperpigmentation and a thing called lichenification. And this is basically thickened skin with exaggerated skin lines. And we can see an image of this here in which the skin markings are much more able to be seen, and you can also see the thick skin. In some severe cases, you can sometimes get these little nodules that can be extremely itchy. The pigmentary problems and the lichenification tends to be a much bigger problem in darker skin types. The hallmark of eczema is itch, and eczema presents as a red scaly rash. Often if you look closely, you may even be able to see these little erosions in the skin. If it's very weepy, or if you see a kind of honeycombish colour, you might have a bacterial secondary infection. So eczema often manifests differently depending on the patient's age. So for instance, in infants less than 1 year old, it often has a predilection to the face, although it can affect other areas and be more widespread. Then as the patient gets to school age, it often adopts a more kind of flexural pattern, particularly around the elbows, around the knees, but also around the ankles and maybe flexural areas of the neck. Then, as patients get older and get into adulthood, the eczema usually improves, but it can still present locally. And in particular, the hands are often affected, around the eyelids can be affected, and then of course the flexural areas also. So here's just some images. Here's an infant with eczema particularly affecting the face. There's the erosions I was talking about. This is probably a school-age child, possibly, and it's almost in a more flexural area, and again it's a red scaly rash. And here's the lichenification, the thickened skin with exaggerated skin markings. There's a particular subtype of eczema called discoid eczema, and it's common enough, and in this the eczema patches are kind of roundish. Other ways they're described are as annular, coin or disc shaped, and this particular type of eczema can be very stubborn, so you might need to treat it with a stronger topical steroid than you would in other type of eczema. So the treatment of eczema, I suppose one thing that I can't stress strongly enough is that you really need to use regular moisturizers. They're very important in repairing the barrier and also in maintaining the water inside the skin. Now, even with moisturizing, if the skin does get a bit inflamed, you might then use a topical corticosteroid. Acne vulgaris is another very common condition that we see in dermatology, and is a chronic disorder of the pilosebaceous apparatus, and this basically means the hair follicle and the sebaceous gland. Now, the infundibulum is the part of the follicle extending from the epidermis down to the opening of the sebaceous duct. And you can get hyperkeratinization in this area. This basically means dead keratin cells don't slough off as easily, and you can get a buildup in this area. At the same time, and for possibly interrelated reasons, you also get an increase in the production of sebum from the sebaceous gland. And this sebum also can't get out as easily due to the blockage upstream. So this is an ideal environment for colonization of a bacteria called P. acnes, and it's able to proliferate here as well, leading to inflammation. And if you get marked inflammation, which is possible, you get rupture of the apparatus and you can get scarring. And this is really the end point we want to avoid in acne. So acne is characterized in order of increasing severity by comedones first, and everyone knows these as whiteheads and blackheads. So here's an image of an individual who's got marked comedonal acne. Here we can see blackheads, which are also known as open comedones. Then if we look at this image, the comedones are closed, and these are called whiteheads. Once you start to get inflammation in these areas, you get papules and pustules, and this is a lady who's quite severe papulopustular acne. And if we look at once the inflammation gets more severe, you can end up getting these deep nodules and cysts, which can actually be quite painful. And this poor lady has quite severe nodulocystic acne. The end result of acne, and the thing we want to prevent, is scarring, which can be very difficult to treat once it has occurred. With regards to the treatment, we can often start with topical treatments for mild acne. These include antibiotics such as tetracyclines. We can also use a thing called benzoyl peroxide, which has anti-inflammatory effects, and it also works by declogging the comedones. And we can also use topical retinoids, such Differin is probably the main one that we tend to use. And this is basically a topical form of isotretinoin, which is also known as Roaccutane. And we'll go into that in a bit more detail in a few minutes. In moderate acne, we often need to add an oral treatment to the topical agents we might already be using. And we usually give a 4 to 6 month course of low-dose oral antibiotics such as tetracycline. Less commonly we use erythromycin, and even less commonly than that, trimethoprim is sometimes used. We can also consider the oral contraceptive pill such as Dianet in females, but we only tend to give it if the patient wants to use contraception anyway, due to the potential side effects of the oral contraceptive pill. And spironolactone is another tablet that has been shown to be effective. Now, if it is moderate to severe acne and these other treatments have failed, or if the patient is scarring, we may consider isotretinoin, which is also known as Roaccutane. Now, it has many adverse effects, but it is extremely effective in treating acne. Side effects include marked dryness of the skin and mucous membranes, especially the lips, and this is to be expected, and it's often a gauge of how effective the Roaccutane is actually in treating how effective the Roaccutane is in treating the acne itself. Now, the main reason Roaccutane is restricted to dermatologists is its extreme teratogenicity. Women absolutely cannot get pregnant on this, and we must exclude pregnancy prior to treatment beginning and also at 1 month intervals during treatment before we can give the next script. The woman should also be on 2 forms of contraception, such as the oral contraceptive pill and using barrier protection. We often get the woman to sign a form saying that she is aware of the risks and that she will take contraception. Now, mood issues is a very tricky issue when it comes to Roaccutane. Many years ago, there were reported cases of patients who committed suicide, and this was linked to them starting Roaccutane. Now, many randomized controlled trials have been performed over the years regarding this, and some of them have been quite conflicted. Now, if there is any link between Roaccutane and severe depression and suicide, it is probably very minimal. However, caution is always applied, and we always ask about a personal or family history of severe depression. If they do have any severe depression in their personal or family history, we might consider referring them to a psychiatrist before starting treatment. Another side effect is you can get abnormalities of lipids and LFTs, and now these tend to be reversible when you stop the medication. However, we usually check these tests before we start the medication just to make sure they don't have any gross abnormalities beforehand, and we might check again at about 8 weeks' time. Other side effects include paronychia, which is infection at the base of the nail. You can also get dry eyes, which can cause problems for people who are using contact lenses. And you can also get increased fragility of the skin. So we warn people not to do any waxing during treatment or tattooing, as if they do, it can get quite nasty. Acne fulminans is a rare systemic disease in which severe and often ulcerating acne is accompanied by fever, arthralgia, and occasionally arthritis. Now, rosacea is a chronic skin condition. It tends to affect the cheeks, the forehead, the chin, and the nose. And it can be characterized by redness, dilated blood vessels, papules and pustules, and often a tendency to blush easily. Women are more often affected, and it tends to occur in the 30s to 60s age group. Now, you can get different symptoms and subtypes of rosacea. One subtype is erythema and telangiectasia of the skin, as seen in this schematic here. Another subtype is acneiform papules and pustules, which tend to cover the cheeks, the nose, the chin, and the glabellar regions, which is between the eyebrows. One very important thing about this type of rosacea compared to acne is that there are no comedones. Another subtype then is rhinophyma, and basically this means irregular thickening of the skin, which often affects the nose, and this is due to enlarged sebaceous glands in the area. We'll look at some of the images of these cases in a minute. You can get an ocular rosacea, in which a patient presents with conjunctivitis and blepharitis. And finally, there is a variant called granulomatous rosacea, which can present as these hard nodules with marked erythema. And when you take a biopsy of this, you'll see granulomas. Now, these are the different subtypes. Here we see erythema and some telangiectasia, I'm sure, if you look closely. And you can also see lots of papules and pustules. So this kind of covers two subtypes. Here we can see a severe variant of rhinophyma I was talking about, with this thickened nose due to larger and increased amounts of sebaceous glands in the nose. Lots of things can exacerbate rosacea. It can get worse by UV sunlight, it can get worse by heat, alcohol, taking spicy foods, and drinking hot drinks. And to distinguish it from acne, we note there are absent comedones. The distribution of the rash is in the areas I mentioned, whereas it tends to be wider in acne. Sunlight makes rosacea worse, and age. So acne doesn't tend to be as common above the age of 30, but you got to note that it can still occur. Moving on to lichen planus, it is an autoimmune disease and is a chronic inflammatory condition. It is thought that the immune system attacks against basal keratinocytes, which are just above the basement membrane, and it often presents as all the P's. So you get these pruritic, purple, flat-topped papules and plaques, and they tend to occur on the wrists and ankles, and you can also get them on the genitalia, but it can occur in any areas really. You often see these things called Wickham striae, which present as these fine, white, lacy, crisscross lines on top of the papules or plaques, and this is a really good example of that. Nail involvement is common enough. You get it in 10% with just these dystrophic nails, and oral involvement is even more common, and it can occur in up to 50%, and you tend to get this almost white, lacy, crisscross appearance on the buccal surfaces of the cheek. If it affects the scalp, you can get a scarring alopecia, so the hair will not grow back, and this type of lichen planus is called lichen planopilaris. It also, like psoriasis, it also shows copnerization, which this basically means trauma causes new lesions in that area. So something as simple as scratching the area can cause new lesions. Lichen planus is often idiopathic, although it does have some associations. It can be associated with autoimmune liver disease, such as primary biliary cirrhosis. It can be associated with systemic viral disease, such as hepatitis C. And drugs is quite a common cause, and the usual culprit drugs are thiazides, ACE inhibitors, and antimalarials. Now, lichen planus tends to resolve in about 12 to 18 months. If it's quite mild but itchy, you may consider giving a topical steroid to treat symptoms. You could also consider phototherapy, such as UVB light. However, if it's more widespread and severe, you may need to give some immune suppression. So you could consider a course of oral prednisolone, or you could consider another agent, and there are many of these, and I will not go into that here. We'll now go on to the topic of erythema nodosum. So erythema nodosum is an acute paniculitis, which basically means it's inflammation of the fat layer, and this can produce painful nodules or plaques, which are usually found on the shin, but they can be found in other areas such as the forearms. It is commonly seen in a number of conditions. Infections such as streptococcal sore throat or TB can occur. It can also be seen in inflammatory conditions such as sarcoidosis and inflammatory bowel disease. Seen in pregnancy, and many medications can cause it as well. So the oral contraceptive pill can cause it, the sulfa drugs can cause it, and other antibiotics such as the penicillins and tetracyclines. But often, like many things, erythema nodosum is idiopathic. The treatment for erythema nodosum is that you treat the underlying cause if found. Then you just give them some bed rest to get them to wear compression stockings. If they're in pain, they can use anti-inflammatories for the pain, and it tends to go away over a few weeks to months. So here's an image of some nodules that would be tender to press, and they'd feel quite deep under the skin as well. And this is a classic area, you see them on the shins. So pyoderma gangrenosum, it's another autoinflammatory disorder, and it's called a neutrophilic dermatosis because lots of neutrophils are seen in the dermis when you take a biopsy. Now it tends to start as these inflammatory pustules or papules that appear on the limbs and the trunks, and they can enlarge rapidly to produce these large necrotic ulcers with a sloughy base. When you look around the border now, I suppose it can be seen here, you see an undermined border, and there's often a very violaceous or purple rim around it. The border tends to be serpiginous, which means it's kind of snake-like the way it tracks around. Um, Now, it can grow very quickly and it can double in size about a week. When you do biopsy, as mentioned earlier, you see an intense neutrophilic infiltration in the dermis and you get necrosis of the overlying epidermis. Now, it can show a thing called pathergy, which is exaggerated skin injury occurring after a minor trauma. So you can get, for instance, you can get ulceration occurring at a site where bloods were taken. Now, there are, again, like other things, there are many associations. So, inflammatory bowel disease is one of the common ones. You often get PG around peristomal sites. Rheumatological conditions such as rheumatoid arthritis and angst can be associated with it. And then ones that you really need to worry about are the hematological malignancies such as leukemia, lymphomas, and myeloproliferative disorders. And other things as mentioned there can cause it as well. Now, it is a medical emergency. It's very important to recognize early. You need to give high dose prednisolone to stop the rapid growth. And then the usual thing that is given is cyclosporin when you tape cyclosporin to get it under control and use as maintenance, and then you can taper the prednisolone down. Now, other regimens may sometimes be used, but that tends to be the commonest one used currently. Moving on to acanthosis nigricans. This is a condition where you can get a velvety thickening and pigmentation of the major flexures. The axilla really is a classic one, but it can occur in the groin, the flexures of the neck, and other areas as well. Now, again, it can have multiple associations. The major one that, again, we are concerned about is that it can be related to malignancy, and in particular stomach cancer. Now, it tends to be a very florid, it tends to present very floridly in these cases, and it's often a late manifestation of the cancer. So I suppose usually they've probably been diagnosed already. Other things that it's associated with are insulin-resistant diabetes, obesity, and the polycystic ovarian syndrome. Many drugs can cause it. I use the NODES mnemonic, so nicotinic acid, OCP, Dilantin, which is an old name for phenytoin, estrogens, and steroids. Now move on to erythema multiforme, Stevens-Johnson's, and TENS. It's a bit complicated, so just bear with me for a minute or two, but the old way of thinking was that erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal necrolysis were a spectrum of the same disease, and this classification has caused a lot of confusion over the years. Now, a recent consensus meeting stated that erythema multiforme is one diagnosis, and the Stevens-Johnson TENS spectrum is a completely distinct clinical disorder. So erythema multiforme, which can be minor or major, is caused by infection or drugs, whereas Stevens-Johnson and TEN is almost always caused by drugs. So in erythema multiforme, you get these typical target or raised edematous papules which are distributed acrally, usually, but they can be more widespread and they can involve the mucous membranes, and I'll have some images of them in a minute or two. Whereas in comparison, Stevens-Johnson's and TEN is widespread shallow blisters and erosions, which affect one or more mucous membranes also. Now then, when we compare Stevens-Johnson's to TENS, we have a schematic here. So Stevens-Johnson's is when less than 10% of the body surface area is affected. Stevens-Johnson/TEN spectrum is when there's 10 to 30% body surface area affected, and then we call it toxic epidermal necrolysis, or TENS, if greater than 30% of the body surface area is affected. So now I'll go into the two various conditions in a bit more detail. So erythema multiforme, it's an acute, self-limiting and recurrent condition that can affect the skin and the mucosal surfaces. It's basically a hypersensitivity reaction due to circulating immune complexes, and it often occurs about 7 to 14 days after the initial insult. You get a hive-like rash with purpura or vesicles in the center, and this is often described as the target lesion or the bullseye. And I'll have an image of it there. This is classic targets that we tend to see, but it's often not that obvious. And here's another case where, they mightn't be quite as classical, but they are almost like hive-like lesions with differences in the center. And so this is also a case of erythema multiforme. So, as I said, the target lesions are not always clear-cut. You often see these lesions on the backs of hands, palms, and forearms, but they can be quite widespread also. Now, erythema multiforme minor is usually just the achial rash, whereas erythema multiforme major is involvement of the larger body surface area and the mucous membranes also. Now, erythema multiforme can be associated with herpes simplex virus, and this is seen quite commonly. So they often come in with cold sores, and then about 2 weeks after the cold sores, they get this type of rash. It can also be seen in mycoplasma pneumonia, and it can be seen in other things. So other types of infections such as hepatitis, HIV, EBV, and all these other weird and wonderful things. Then drugs can cause it. So the sulfa drugs again, the barbiturates and penicillins are associated with it, and internal malignancy as well. But I'm not sure how common that is actually, to tell you the truth. So then that's erythema multiforme. So now moving on to Stevens-Johnson's and toxic epidermal necrolysis. It's a severe reaction in which there is sheet-like skin and mucosal loss. And the mucosal membranes we have to look out for always are the mouth, the eyes, and the genitalia. So if this is considered, you always have to examine these areas to look for any erosions. It is almost nearly always caused by medications, and I'm not sure why, but it is 100 times more common in association with HIV infection, and it is absolutely a medical emergency. So here we see this would be described as toxic epidermal necrolysis. So toxic epidermal necrolysis is a more severe variant of Stevens-Johnson's, in which greater than 30% of the surface area is affected, and you often get these burning macules. So the rash is often flat at the start, but the patient can sense it burning, and then it can spread rapidly over the body, and then you get these the shedding of the epidermis to reveal a moist dermis underneath. So here we see a lady that's got severe rash, and you can see there's marked desquamation of the skin there, and she's quite unwell. This would show also a thing called Nikolsky's sign. So if you were to rub your finger along this area here, the skin would just slough off. And here's oral involvement with erosions of the mucous membranes of the mouth. Now, skin biopsy aids in diagnosis. It will basically show full epidermal necrosis. So the management, obviously we want to withdraw the offending agent, and then they should ideally be managed in a specialist plastic or burns unit, or at least an ICU. And the mainstay is really just very careful skin, oral and eye care. You treat any infections with antibiotics, and then use of other agents such as steroids, IVIG and other immunosuppressants is quite controversial. So it really is very intensive supportive care, plus or minus other agents depending on who's managing them really. Now there are a variety of causes. Usually occurs within the first 8 weeks of starting the drugs. So I think of all the A's, so antibiotics such as beta-lactams and sulfonamides are a big one, such as cotrimoxazole. Then the anticonvulsants, lamotrigine, carbamazepine, phenytoin, phenobarbital, allopurinol, and then the anti-inflammatories. So simple garden variety NSAIDs can cause this, so you always need to have a very, very comprehensive drug history.